Today, Memantine for inappropriate sexual behaviors in dementia, what a case report shows and what it cannot prove. Inappropriate sexual behavior, ISB, is one of the most challenging behavioral symptoms in dementia. It includes public masturbation, unwanted sexual advances, and sexually disinhibited remarks. Prevalence ranges from 2 to 17% of dementia patients, and it is a leading cause of institutionalization and caregiver burnout. ISB reflects neurodegeneration in frontal and temporalimbic circuits, the brain networks governing impulse control. When these structures are damaged, disinhibition occurs. Standard management includes behavioral modification and environmental adaptation, but the evidence base for medications is thin. Antipsychotics carry boxed warnings in dementia, and other agents have limited data. This is the clinical gap this case report addresses. Memantine is an uncompetitive NMDA receptor antagonist, FDA approved since 2003 for moderate to severe Alzheimer's dementia. It modulates the glutamatergic system, unlike cholinesterase inhibitors. Its mechanism is relevant here. NMDA receptors regulate synaptic plasticity in frontostriatal circuits. By blocking these receptors, Memantine may reduce glutamate-driven hyperactivity in circuits that, when dysregulated, produce impulsive and disinhibited behavior, the same pathway hypothesized for obsessive-compulsive disorder. Memantine's approval is limited to Alzheimer's dementia. Using it for ISB is off-label, and the mechanism hypothesis is unproven in this context. The case report by Hafeez and Jahed describes 2 patients with ISB refractory to standard approaches, both treated with Memantine as an adjunct. Case 1. A 67-year-old man with intellectual disability, MoCA 16 out of 30. Over about 18 months, he developed worsening ISB, public genital touching, inappropriate propositions. Memantine started at 5 mg daily, titrated to 10 mg twice daily. Combined with behavioral therapy, his ISB resolved. Cognition remained stable over 3 years. When ISB recurred 2 years later, increasing Memantine to 25 mg daily brought it under control. Case 2. A 73-year-old man with vascular neurocognitive disorder and severe ISB, compulsive masturbation, sexual aggression, genital injury. Memantine added to his risperidone, titrated to 10 mg twice daily. Aggression resolved completely, and compulsive sexual behavior decreased markedly. Neither patient had a formal discontinuation trial, both remained on drug long-term. These are 2 cases, not a trial, and outcomes cannot be generalized without controlled research. What does this case report actually tell us? The glutamate hypothesis for ISB is biologically plausible. Frontostriatal and temporalimbic circuits regulate impulse control, and glutamate dysregulation is implicated in behavioral disinhibition. Memantine's NMDA antagonism could theoretically modulate these circuits, but this remains a hypothesis, not proof. The 2 cases show signal, not evidence of effectiveness. Both patients responded to Memantine 10 mg twice daily as an adjunct. Case reports cannot establish causation or control for placebo response. For clinicians, off-label Memantine for ISB is reasonable in severe cases refractory to standard care, given its favorable tolerability compared to antipsychotics. Set appropriate expectations with patients and families. Monitor for dizziness, headache, constipation. And recognize this approach is investigational until controlled trial data emerge. The bigger message, ISB in dementia needs more systematic study. Case reports like this can generate hypotheses, but we need controlled trials. For questions or episode ideas, drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.